Okay. Thank you, Tessa. Fantastic job organizing this. So just so I'm clear, do we have, is someone doing the Q&A online? How is that? Is she's okay. Good. Okay. So every year, this is one of the most meaningful weekends for Dr. Hardesty and myself, and our team at Alaska Women's Cancer Care, because we get to bring to Alaska in February when it's -degrees and dark, the time everybody wants to visit, our colleagues from around not just the country, but around the world this year to come and share their expertise with us and with you all, with the goal of as we move forward in the cancer journey together, of being better partners in care together. So we believe, Dr. Hardesty and I believe, that the more our patients and our families and our community know about gynecologic cancer, the better advocates you can be in your own journey, and the better we can come up with the best treatment plans possible as we navigate the process together. So so one of the things that this conference does is it brings knowledge to us here, which is extremely important. The other thing that it does is it exposes the world around us to what we're doing here in Alaska, and which is also extremely important. And over the 12 years that we've done this, we've had gynecologic oncologists and speakers and scientists and doctors come up here and see what we're doing here in Alaska, and it basically creates a pipeline of sharing of information in years that succeed the visit here. So as long as we don't freeze them to death, we hope that this next batch of incredible guest speakers will continue in that tradition and help us deliver better and better care to our patients here. So the first speaker is our international guest. She took her 4 flights and 24 hours to get here. This is Dr. Carol Williams. She drank the Kool-Aid last winter and decided to join us on our Everest trip. And after that, I recruited her while she was hypoxic at the base camp to come here in February. And then once that was done, we convinced her to come up Kilimanjaro as well very soon. So Carol, come on up here and get mic'd up while I try to get your intro correct. So Dr. Williams is a gynecologic oncologist. She's a clinical teacher and professor. She's at
Dumont University Health Center in Moncton, New Brunswick.
In New Brunswick. All right. Now, do you want to, the picture adds 10 years. That's not you. This is not her. And it's actually not where she works either. No, it's we did that. Come on over here. So yeah, let's mic up with that. Do you have her? You're going to. My picture, which is not up here, thank God, is like about 20 years younger than I am. So yeah, that's not true.
Can anybody hear me?
Yes.
And online too, I'm sure. All right, I'm gonna say that it's fine.
So is her talk?
It's right there.
Okay, good.
So mouse. Oh, all right. So it's on the screen.
Just talk loud, assume that we're all deaf, okay?
Yeah.
All right.
Or I can just put the volume up. So if I click this, it's gonna go on the screen?
Yep, there it is.
All right, nice. All right, welcome everyone, in person and online. I'm glad to be giving the first talk while you're all still asleep. It's going to be a quick talk. It's nothing scientific. It's for everyone to enjoy. I know it was meant to be a Stump the Professor, where usually we present really strange, difficult cases. This is not the case here. It's just for fun and to expose a little bit of what's going on in my end of the world. And where is that? Moncton, New Brunswick. It's in Canada. So Canada is really close to here. We're your very close neighbors. I was Googling, and about 400 miles if you drive that way, you're in my home. But I'm from Atlantic Canada, which is quite a little bit further. So 4,780 miles in that direction. I'm on the East Coast, the other ocean, and that's why it took me so long to get here. But I'm happy to be here. Why am I presenting where I'm coming from? Well, Moncton, New Brunswick is really a small city. When I drove through here last night, it really reminded me of Anchorage, where the population, the general population is probably around 200,000 now in the metro area, but we're a very homogeneous, white, European descent. We're a young-ish population. So that's why I find it amazing that we have so many of these outstanding cases in this very bland, ordinary area of the world. We're not multicultural, multi-ethnic. We're not a mixed pot of populations. We do have, we are on native lands, of course, and the First Nations people in our area are the Mi'kmaqi and the Wolastoqey. But they're very much a minority of our population. We're just boring white European people. It's a beautiful area to be in. If you want to visit, I strongly encourage you, and don't worry about the 24-hour traveling. So meet my Canadian friends. I'm gonna present these ladies to you as my friends. So we're gonna start right away. So first case, who's not my patient, but it was an interesting one. So we all sort of know her. She was a very young lady, working up her infertility, waiting on IVF, when her endometrial biopsy demonstrated an endometrial cancer. So she was already in her process. So our objective was to try to reverse this endometrial cancer to allow her to have her embryo transfers and her pregnancy. So my colleague started her on high-dose progesterone and followed her. It took over 2 years of therapy, 2 years of follow-up to gradually reverse this endometrial cancer. So this is not an overnight thing, but it can be done. So in May 2022, finally, she came back with a normal biopsy and we said, go. So unfortunately, so we put the progesterone on hold, we put the therapy on hold, and she went to do her IVF, 2 failed attempts. And so she did not become pregnant, unfortunately. During this time, her therapy was on hold. So eventually, January 2023, she started having symptoms. And of course, the abnormal cells had come back. So we started her therapy again, but at this point, she was okay with going for surgical treatment. When we started to work her up for this surgery, we started noticing that there were signs of tumors elsewhere in her belly, which is very unusual for precancerous cells or for a very low-grade cancer. So we were wondering, what's going on here? So what could it be? Could it be that her cancer has spread so fast that it's now all over her belly? Could it be a second cancer? Carcinomatosis means tumor all over the belly. So this is typical of ovarian cancer, but why would she have this? So when she went through for her surgery, she did, in fact, have all this disease in her belly. And at the final diagnosis, we got the surprise that she had, in the meantime, developed a very rare ovarian cancer that was already widespread through her belly. This had nothing to do with her endometrial cancer. And from what I could research, it had nothing to do with the therapy that she had to become pregnant. So it's purely a coincidence. So we caught it early. Early-ish, as early as possible, and she got her therapy, and now she is, unfortunately, she is not, she did not get her pregnancy, but she's cancer-free for both her cancers. I don't know why that stopped. Sorry. It said that I logged out. I didn't log out. I don't know if the people online can still see the slides. I hope so.
I think what makes you worried that they can't?
just because those screens shut
No,
off.
these screens are working. These screens have
Okay.
been, we're working on the problem over here,
Okay.
but we can
Perfect.
see your screens over there.
Okay, perfect. All right, so just a little line on ovarian germ cell tumors. They're very rare, so probably less than 5% of all ovarian tumors. They're more prevalent in younger Asian women, which our patient was. Yolk sac tumors in this 5% of ovarian tumors, they represent 15% of these, which is very, very rare. And it is described as a rapidly growing tumor. So it's not surprising that we turned around and she had this tumor all over her belly. So other types of this ovarian germ cell tumor family can include teratomas, dysgerminomas, choriocarcinomas, and embryal carcinomas. So these are all very rare. But I'm going to present to you case 1.5.5.5, the triplets. So it just so happens that we have had many, many cases of patients presenting with suspicious ovarian cysts that turned out to be malignant struma ovaries. So the first patient I had about 10 years ago, we didn't even know what this was. And at the time I did literature research and there were less than 200 cases in the world, published cases. And now we have 5 just in the Moncton area. I don't know what we put in the water, but it grows thyroids in ovaries. So that's essentially what it is. So it's a thyroid tissue that grows into an ovarian cyst. And when the thyroid becomes malignant, you develop an ovarian thyroid cancer in your ovary. They were managed very differently. Like I said, when I had my first patient 10 years ago, we gave her full ovarian cancer treatment and full thyroid cancer treatment because we didn't really know how to treat this patient. And she's cancer-free after 10 years. But the other ones we treated a lot more conservatively and they seem to be doing well. So we treated only the ovarian cyst per se, not the thyroid. If ever this would be to come back, it would be an easier cancer to treat. So teratomas, dermoid cysts are the ones with the hair and the teeth and all of those nice tissues in the ovaries. They're very common, but the malignant ones are very, very rare. And struma ovari represent less than 3% of all of these malignant cases. So I'm going to present to you one of our more experienced patients, 90 years old. Typical complaints of abdominal discomfort, bloating, loss of appetite. She was not doing well, and she did present with ovarian carcinomatosis. We always present all the aspects to our patients, and she was very comfortable, along with her family, to start a palliative treatment with extremely low dose chemotherapy. And so she got very, very slow progressive treatment for her ovarian cancer, thinking that this would just slow down the disease. And she is now many, many months later and living her best life at 91. So, you know, sometimes we don't think that it's going to work, but it sometimes does. So we always offer all the options to our patients, and in some cases it does work out. And another case of sometimes it just works out is my lovely patient. We'll call her Dory. I met her, of course, these catastrophes always happen when you're young and inexperienced. So it was my first week as an attending. She presented with very, very heavy vaginal bleeding. And we knew from her biopsy that this thing in her uterus was really nasty. She bled so much that we had to do an emergency surgery on her, which is very rare. But we just had to go in and settle that hemorrhage. We had started her workup, but we did not have time to complete it. So after we did her hysterectomy, then we staged her and we saw that she already had a tumor in her lungs. So she had metastases from the beginning. We said, look, this is, it ended up being a leiomyosarcoma. And we said, this is a very bad prognosis. We're going to do palliative treatment. She said, okay, I'm okay for anything. So we gave her palliative chemo, 6 cycles. She tolerated very well. We were thinking, you know, do we need radiation now that she's doing so well, just to control the pelvic aspect of things? So when we worked her up for radiation, we found metastases in her vagina. And so this was a doubly metastatic disease. She wanted to do the radiation anyway, so we went through that with the palliative intent, and while following up for her radiation treatments, we found more tumor in her other lung. So this was not looking good for Dory. She accepted to do another round of palliative chemo. We switched the chemo type. So she had more chemo up until 2012, and then radiation to the residual lung lesion. Surprisingly, she was doing very well after that for a couple of years until the second lung lesion started growing again. She got more radiation, no more chemo. And the lesion was still present after her radiation treatment. So this was not looking great for Dory. But what happened next is that a few months later, we rescanned her and the lung lesion had completely disappeared. This was in December 2015. And I discharged her in September 2022 because she said, Dr. Williams, I'm healthy. Why am I still seeing you? And she wanted to stop seeing me. So doing is now 70. And so expect the unexpected. Sometimes it can work out. Is there a way to get rid of this so that I can see my slides? Thank you. So Dory just kept swimming. Oh, it's not working anymore though. Okay, can I try? Okay, so leiomyosarcomas are very, very rare tumors that are very aggressive. But as you can see, there's ways to keep them under control and to treat them. So the only thing that set this patient apart was her extremely positive attitude. She was willing to fight. She was willing to undergo any treatment that we would offer her. She was surrounded by loved ones, but I think in the end, a lot of luck came into play here. She got very lucky. The unexpected one is a person who was assigned male at birth, who decided to undergo gender affirmation surgery in the 90s. So a really long time ago, we didn't have the technology that we have now for gender affirmation surgery. She's an active smoker, and she did not have regular gynecological exams for her neovagina. When she discovered lesions herself, then she consulted a gynecologist, and she had atypical cells. She had dysplasia of her neovagina. So she was referred to me, and indeed she did have some genital warts and she did have some abnormal cells inside this new vagina. So we lasered all of that. She was very happy that she got a pregnancy test pre-op. That was affirming. And in her follow-up, everything came back normal. Again, her Pap test showed lack of endocervical cells in a woman with no history of hysterectomy. She was happy with that too. So she's doing good now. So just a reminder that HPV affects both males and females, whether you were male at birth or female at birth. It can affect anyone. Any direct contact can spread HPV, even though this was not a natural vagina, it can still be affected. It's very common and widespread. Best measure to prevent this is vaccination, and best screening method is HPV testing when available. All right, so I'm going to present you my biggest case. It's the big one, but it might be the biggest one in literature from what I've researched. My patient presented when she was 50 years old. She was already menopausal. She was brought in by ambulance after she fell in her home. So when the general gynecologist called me and said, hey, I have to transfer you this patient with an ovarian cyst, I was like, well, you don't need to transfer her. I'll just, give me her number and I'll call her next week for an appointment. She said, no, you have to see her now. I can't send her home. So that's when I met my patient. She could not go home because the reason she had fallen is she was bound to her chair for the past 3 years. And in the meantime, this gigantic ovarian cyst had progressively developed. This was during COVID. So she was homebound, chair-bound, and did not present until she had to. Surprisingly, she was still functioning. She was working from home, and she had no other symptoms other than this big, big cyst. When I reviewed the literature, the people presenting with cysts bigger than 100 pounds usually had a very, very poor outcome. And this was usually from surrounding the surgery, the fluid shift created by removing suddenly this type of a mass. They did not survive. So we had to make a decision. We had to get her in the best shape possible for this surgery. And eventually, reviewing what was available, we decided to drain her cyst. So we're not supposed to puncture, we're not supposed to biopsy ovarian cyst because of the risk of cancer. But in this case, we sort of figured this was our best bet for her to survive surgery. So we transferred her to intensive care and drained slowly this big ovarian mass. It drained about 10 liters per day. That's what we limited ourselves to. And it was like mucousy fluid, as you can imagine. This was a big mucinous cyst. We decided to do her surgery after about a week of draining, and then she caught COVID. So her surgery was deferred. So we did continue to nourish her because we drained and she was feeling a lot better. She was able to start eating. She was able to start physio. And this was all before surgery. She walked for the first time in 3 years. I saw it with my own eyes, and it was amazing. So we kept draining a little bit after her COVID diagnosis and decided on a new surgery date. So by the time her second surgery came along, we had drained about 200 pounds of mucus. So when the patient presented, we weighed her in her bed, and she was weighing 442 pounds with her tumor. This is her after draining 200 pounds. So it was still a giant, giant cyst even after draining. We removed probably 50-ish pounds at surgery. Collaborative surgery, anesthesia was very much involved. We involved plastics right away to help us open and close this thing. So this is the incision they had decided. And everybody was on standby for us. But this being said, surgery went extremely well, no problems at all. She was discharged on the 4th day. This is her a month after. Other than having lots of extra loose skin, she was already doing extremely well. At 1 month after her surgery, she had lost a total of 300 pounds. So she's a tiny little woman. She's 5'2" and 140 pounds normally. And she came in at 442 pounds. Final pathology showed benign mucinous, completely benign tumor. She is now super active. She thanks me every day for giving her life back, from being in a chair for 3 years to walking 5 miles a day. I'm very happy. She's waiting for her final plastic surgery to remove all that extra skin. So lessons that I learned reviewing literature is that draining giant ovarian cysts may be our best option if ever you're faced with this. It's a risk to take, but it's definitely less morbid when surgery comes along. And this is probably top 3 in the available literature. So it's going to be a publication someday. If you see her go by in the texts, that's our patient. That's the biggest one. There you go. So this is where I come from. If you want to visit, we have beautiful scenery, beautiful ocean. Thank you. Sorry, this is the last slide.
Nice. Take that on. Hand that to the next person. Thank you. Testing. Hello, hello. Yep, that's perfect.
Okay, thank you so much, Dr. Williams. Next up, we have Dr. Katie Pennington. Dr. Pennington is a gynecologic oncologist at the University of Washington in Seattle, and she is going to speak to us about breaking down genetics, the who, what, when of germline and tumor testing. It is also my tremendous pleasure to introduce Katie. We have recently made the decision and invited her to join us as the 3rd gynecologic oncologist, and she's going to be moving up to Alaska in this summer with her husband and her son. Her husband is an anesthesiologist and an intensive care, critical care doctor. So please give her the warmest of welcomes. We could not be happier. And it's just, Katie's going to be an unbelievable addition to our state.
Thank you so much. And I just can't tell you how excited I am to be coming here.
Do you
So,
want this or do you want that? What's your preference?
yeah, maybe that.
Okay.
Can you hear me?
Lost online. You're just a presenter.